Repair of an Achilles tendon rupture using the PARS system. Conflicts of interest: I'm a stockholder with Sonics Health. I'm also editor of an MSK Ultrasound textbook and speak for Expert Education. This is two parts to this repair. Part one is using ultrasound to position the PARS guide on the proximal torn tendon for passing needles, tapes, and sutures. The second part is using ultrasound on the distal tendon to pass a suture retriever and position the distal anchor holes. The eventual goal is locking sutures in the proximal torn tendon and anchors distally on the heel. This is done with a device that has inner and outer guides. The inner guide is placed inside the sheath of the triceps surae tendon and muscle, and the outer guide is on the outside of the skin. We first use ultrasound on the long axis to pick our incision site, which is at the site of the rupture or perhaps slightly proximal, so that we can properly grasp the end of the tendon. We start down by the heel, and just deep to that large vein, one can see the sural nerve and know where it is. We can follow it up the leg. We can see it just adjacent to that vein there and know that we don't want to bring our incision that far laterally. And finally, we can follow the nerve proximal to the tear and know how to avoid it. Having made our incision, we can then grasp the torn end of the proximal tendon and we can do a blunt dissection. It was a little more extensive in this patient because he was 9 days from the date of injury. Then you can pass the inner portion of the guide in the sheath and see its position relative to the proximal tendon. And we can watch the first needle pass from medial to lateral. If I were to criticize this, I would say that our needles are a little bit too anterior, more anterior than I would want. Here is the crossing needle. And finally the third needle, and one can again see that we are avoiding the sural nerve. Here we see the needles as we come down the short axis of the tendon. We then bring the proximal sutures, indicated by the black arrows, into the tendon so that they exit in the center of the torn portion of the proximal tendon. Then we go down long axis onto the heel and select the appropriate place for placing our anchors, which would be right about here. Then we take a suture passer needle, like one would use in a rotator cuff repair, and pass it from distal to proximal. But we can see in this that our needle is far too medial and far too superficial. One has to pull the needle pass her all the way out and then repass it. This is a much better position. We can see that it's in the mid portion of the tendon. And when we switch to the short axis, we can again see that the needle is in the mid portion of the tendon. We then make our final construct by passing the sutures out at the level of the heel and adjust the tension and fix the anchors. So in summary, the ultrasound, I think, is very helpful with this repair. We can use the guide to position our incision, and the proximal needle placement, I think, is really a two-person job. The surgeon holds the PARS guide and the probe, while the assistant holds tension on the proximal tendon and places the needles. And then ultrasound allows proper distal anchor placement and passing of the sutures. Thank you for your attention. For more interesting cases, please consult our textbook